Hello and welcome to this webinar, which is brought to you today by ESTES, European Society for Trauma and Emergency Surgery. The webinar is on multiple organ failure after polytrauma, and I'm going to hand over in a moment to our two moderators, Jolt Balloch and Roman Pfeiffer. So I'm going to hand over now to Roman to start the proceedings. Roman.
Good evening. I would like to welcome everybody to this webinar. So I think we have very distinguished and very perfect guests here to discuss and speak about multiple organ failure. We have Raul Coimbra here from San Diego, Alco Hitbrink from Netherlands, and Professor Zolt Balloch from Australia. And the panelists are Professor Marzi and Professor Pape. And I think this is will be a very exciting discussion this evening, and I think we'll start with our first presentation from United States, Professor Coimbra speaking about epidemiology, outcomes, and definitions. Thank you.
Thank you very much, Dr. Pfeiffer, Dr. Balog, and to ESTES for the tremendous honor of participating in this important webinar on post-traumatic multi-organ failure. I was assigned to talk about definitions, contemporary epidemiology, and outcomes. I have no disclosures except that I'm the editor-in-chief of the Journal of Trauma and Acute Care Surgery. Perhaps some of the things that I'm going to discuss here were published in the past in the journal. So I would like to start with a brief description of the issues that we have with the definition of multi-organ failure. It's actually kind of interesting because the first issue, the first controversy starts with who described it. Some say Arthur Bowie described it, and others say Ben Eisman described it. So even at that level, we have controversy since the beginning. There are multiple scoring systems that are used to define multi-organ failure. I'll mention some of them to you, but we don't have time to go into detail. But these multiple scoring systems also create confusion. The other point of discussion and confusion is that post-injury multi-organ failure should be defined only at or after 48 hours from admission to avoid the consequences of physiologic changes related to the injury itself. Therefore, multi-organ failure scores are only valid at or after day 3, not before that. And a lot of people don't understand that. And most of the epidemiology and pathophysiology that we know about multi-organ failure came from studies about sepsis and not studies about trauma. However, the pathophysiology is similar. They are not quite the same. So moving on to the incidence. The incidence of multi-organ failure, when you read this literature very carefully, is extremely variable because the scoring systems are so different. One paper uses one scoring system, the other paper uses a different scoring system, and there is tremendous variability in the incidence from 7% to 80%. So I ask, can't we just use a simple definition that doesn't use scores? For example, 2 organ dysfunctions with onset greater than 48 hours after severe injury would be pretty straightforward, and forget about the scores. The variability that those scores introduce may also be related to temporal improvements in early resuscitation and ICU care. Obviously, now we are providing better care to our trauma patients from the moment they hit the ambulance or they hit the door of the trauma center or they go to the ICU. And obviously, having less deaths during that time period may actually increase the incidence of multi-organ failure or eventually decrease if we did a really good job. And that's another point of controversy. But we also know that blunt trauma leads to MOF more often than penetrating trauma. Males are more commonly affected than females. The elderly is more commonly affected than the young patients, and patients with comorbidity also have a high incidence of multi-organ failure. Now, one of our moderators, Dr. Bailog, published recently in the Journal of Trauma and Acute Care Surgery a paper where he challenges the concept that the incidence of multi-organ failure is decreasing because we are just providing better care up front. And he says that it's not decreasing. What there is, as I described, is confusion on the incidence because people use different scores. So, for example, if you use the Denver score for blunt trauma, the incidence is 12.7%. But if you use the Marshall score for blunt trauma, the incidence of 20.3%. And if you use SOFA for blunt trauma, the incidence is 55.1%. So I would disagree a little bit with Dr. Bailog, because I don't think this has anything to do with the incidence. This has everything to do with poor definitions of these scores. The incidence is what it is. And I truly believe that if we improve care up front and we optimize physiology as fast as we can and decrease the amount of trauma-induced coagulopathy as fast as we can and prevent iatrogenic organ dysfunction like in the past when we induced ARDS and acute kidney injury in patients because we flooded them with crystalloid, I think the incidence of multi-organ failure has decreased dramatically. In fact, I don't see in my ICU ARDS, post-resuscitation ARDS anymore, and the incidence of AKI, acute kidney injury, and renal failure is decreasing dramatically. Now, moving on to risk factors other than the epidemiologic factors that I described, we also need to take into consideration that this variability in the incidence may be related to pre-hospital transport time. So if it takes 4 hours for your patient to get to the trauma center versus 12 minutes, that's the mean average time in San Diego, obviously the incidence of multi-organ failure will be different between patients with the same mechanism, same age, and same injuries. Fluid resuscitation also affects. I mentioned crystalloids in excess leading to ARDS in the past. And we know that now we rarely use crystalloids to resuscitate trauma patients. Large transfusion blood volumes. People talk about greater than 10 units of PEC red blood cells or risk factor for multi-organ failure, blunt injury, inhalation injury, ISS greater than 25, so severe injuries, shock and hypotension, particularly prolonged shock and hypotension that goes unattended, abdominal compartment syndrome, and persistent acidosis. All these factors add to the variability in the incidence depending on their presence or absence. Mortality is also extremely variable. Studies describe mortality varying from 30 to 60%. And obviously, this varies according to the mechanism of injury, to the number of organs involved, to pre-existing disease. There is a direct correlation between obesity and high BMI greater than 30 and mortality in multi-organ failure patients. Males die more often than females, and also there is genetic predisposition. So in terms of pathophysiology of sepsis, pathophysiology of multi-organ failure, whether it's sepsis or trauma, these are the common elements. There is a microcirculatory problem that leads to increased leukocyte adhesion, endothelial dysfunction, microvascular thrombosis, increased permeability, rheologic alterations, and altered perfusion. There is also gut ischemia and reperfusion, particularly in those patients that have prolonged shock, leading to activation of inflammatory mediators that are transported through the lymph to reach the central circulation, leading to organ dysfunction distant to the site of injury. Obviously, we all know about systemic inflammatory response syndrome, or SIRS, that's characterized by the cytokine storm, release of acute phase reactants, overwhelmed SIRS, and then the release of pathogen associated and damage associated molecular patterns, which are molecules that binds to pattern recognition receptors, or TLR receptors, TLR2, TLR4, and others, toll-like receptors, and then activate intracellular cascades that lead to synthesis of proteins that may be deleterious to the host. This all ends in cellular hypoxia, mitochondrial dysfunction, and cellular bioenergetic failure, which is the hallmark of multi-organ failure. So if you take a modern look at multi-organ failure today, after trauma, you have initial tissue injury, tissue ischemia and reperfusion due to shock, perhaps a positive contributing factor of blood transfusions, negative contributing factor cholinergic response, leading to this genetic storm that leads to the activation of the whole immune system, whether it's the adaptive or the innate immune system, involving all cells, including the endothelium, complement cascades, coagulation cascades, and the toll-like receptors. This culminates with the synthesis of a multitude of inflammatory mediators and leading to this exaggerated innate immunity and the suppressed adaptive immunity. The end result is what I just described in the previous slide: microvascular thrombosis, epithelial and endothelial barrier failure, mitochondrial dysfunction, cellular disruption, and apoptosis, which is the hallmark of organ dysfunction. So some patients will develop this overwhelming inflammatory response and will develop early MOF and will die very early on. Some patients will have their adaptive immune system response kicking in, what we call CARS or SARS, to overcome SIRS, and eventually they will develop late MOF. And some patients, this balance between SIRS and CARS will be enough to lead them to early recovery, and they will do well, but some will continue in this chronic state of inflammation and immune suppression, and will go to what we call prolonged inflammatory, persistent inflammatory or catabolic syndrome. So here's a more comprehensive slide. So early SIRS, MOF, early death. If you are able to compensate SIRS with CARS, you may have rapid recovery and then you go home. But some patients stay in this pro-inflammatory state and this anti-inflammatory state that coexist for some time, that may be as long as 1 year. And they end up having what we call now PICS or CCI, which is persistent inflammation, immune suppression, and catabolism syndrome, or in a more summarized term is chronic critical illness. These individuals actually, they go on to die actually in a significant amount. Those that have a rapid response and recovery, mortality is about 5%. Those that linger for a year with this chronic inflammatory state, mortality is about 41% at 365 days. And their functional status is much worse than those that have a rapid response, which the majority is still having a year out severe disability. So this is not just an acute problem, but now we recognize that this is also a chronic problem that happens in trauma patients. So in conclusion, same disease, different scoring systems creates confusion. Genetics play a major role in the outcomes. Advances in trauma resuscitation and critical care decrease the incidence and mortality of trauma-induced MOF, while sepsis mortality remain the same. This is an important point. And I'm a skeptical man. There is no magic bullet to treat this. Thank you so much for your attention.
Well, thank you very much. We decided previously that we go over the presentation, and in the end have a time for a discussion. And the next speaker is Professor Hedbrink from Utrecht, and he's going to speak about risk factors and predictors. Thank you.
Okay, thank you very much for allowing me the honor to be part of this webinar. My assignment was to talk about risk factors and predictors. Let's see if it works. So I thought to make it a little bit broader, first talk about the drivers of outcome after trauma. We can divide it in patient injury factors and possible alterations that we can pursue to get a better outcome. So the first one I think is important is the trauma mechanism. Most prevention programs like Don't Drink and Drive, they attenuate severe injury. I think there are some specific measures or prevention measures that can be taken being launched out of your car to prevent anatomical location of injuries, or to prevent a massive amount of tissue damage by specific prevention measures like the airbag. And of course, it's important to have a healthy living and prevent pre-existing comorbidities. So these are all the things that also are in play when we are looking at a patient, but not so much things we can prevent or alter in our patient. So the main goals I think we should focus on in risk factors and predictors in organ failure are the physiology and immunology of the patient, because our treatment strategy will be able to attenuate or make worse the outcome of this patient for this condition. And I think this is where our main function as a major trauma center comes in. So we either are here to prevent exsanguination or to save as much functional limbs as possible. And treatment strategy has changed a lot over the past 30 or 40 years. So from early total care with major hepatic resection after major liver injury to damage control and some packing or to get to the next phase in a patient. It's made survival a lot better, but also induced some new problems. And we think we do that by getting the patient to the right place and in a more still harbor by putting focus on structure and time. So I think most of us in the major trauma centers have dedicated floor plans where everybody should be, team training, crew resource management, and techniques to hasten the procedures of these patients. So we looked at our current times. Currently in our hospital, we go to the ED, from the ED to the OR in about 30 minutes for the most severely injured patients, and from ED to OR to ICU within 2.5 hours. I think that's important to optimize outcome, to get to the damage control procedures and get the patient to the ICU in a more stable condition. I think overall, we put together the data after the initiation of the trauma regions in the Netherlands and the adaptation of the damage control principles, the team training and dedicated patient journeys. We reduced mortality with 75% over the last 20 years. I think the most astonishing fact in this part is that it's mainly due to a decrease in exsanguination. So where about one-fifth of the patients died of exsanguination 20 years ago, down to 3%. And that brings us to the first risk factor. So I think the first risk factor is when you take out the possibility to die from major bleeding or pelvic fractures, lung bone fractures, abdominal injury. We take out this part of the trimodal distribution of death. You are left with the last part of the trimodal distribution. So survival is the first risk factor to develop organ failure after a couple of days. I think that's in line with what Professor Coimbra just said, that the MODS score should only be started after 2 or 3 days. The second risk factor, I think, can be numerous. There are multiple studies that have done multivariate analysis, and most factors that reappear in every study is higher age, increased ISS, severe neurological injury, massive bleeding, major transfusion, coagulopathy. And I think this all boils down to being severely injured. So the second risk factor is being severely injured and survive your injury to be able to develop multiple organ failure. And I think our current strategy is to attenuate organ failure in severely injured patients, either resuscitation strategy or surgical strategies. And they are based on known risk factors, or at least what we think that should be risk factors. Also, this has been stated before, but one of the things that's induces organ failure is drowning our patients. So liberal use of crystalloids is related to development of organ failure. There are probably some cutoff point at 10 to 15 liters. And that's true for both ARDS and multiple organ dysfunction. So be low on the water. And the other part is that the patient should be reorganized back to normal physiology as soon as possible. I think this is a nice example of this is the base deficit of two patients. So the first one is coming in rather nicely with a base deficit of 4, but then we drop the ball, and it takes a very long time to get the patient back to normal physiology. While the other patient comes in with a base deficit of -13, is being corrected rather rapidly, and has an uneventful course. So return physiology to normal ASAP should be, I think, the goal. So the resuscitation strategy, not too much water, is a major risk factor. And then I think major part of organ failure is that it's determined by the immunological response to injury. We should find a way to attenuate this immunological response. And we know it's caused by a first hit. So you're a healthy person hitting a car, hitting a tree or something else. And then you have this bimodal distribution of your inflammatory response, during which you probably get a second hit by the surgical team. And the combination of the burden of trauma and the added burden of surgery will determine the total inflammatory response in a multiple hit model. And we have a difficult task in decision making. We started off with early total care from damage towards damage control principles, and now I think most of us adapted early appropriate care. And early appropriate care means that the patient determines the tempo, the indication, and the timing. But it's very difficult to find a good solid ground, because based on what elements or parameters should we take the patient back to the OR or keep continuing with surgery? Lots of cytokines have been proposed. This is IL-6 in a very easy schedule. So I always find it very difficult. And the problem with IL-6 is there's multiple functions, both pro-inflammatory and anti-inflammatory. Can be used as a marker, but it's not very specific. This is one of the studies that's been done. You see the sensitivity is really low due to the large interperson variability for this parameter. Here are some other schedules for immunological parameters that's been studied. They're, well, for me at least, very difficult, and I'd like to keep things simple. So one of the things that meets the eye is the big cell on the right. And if you look closely, there are a lot of factors combined within this parameter. So where you can, keep it simple. There we go. So all the factors combined have influence on this cell. So this is the neutrophil, the final common pathway of multiple cytokines, chemokines, coagulation factors, and angiogenic factors. The normal function of neutrophils is to catch bacteria and kill them. But you can actually look at them, how they appear, how they function, and they might be different. You can do that with flow cytometry. So taking some blood from the patient, label the cells, put them in a laser, and then you can have a readout of how the cell looks and how it functions. Under normal conditions, these cells are rather homogenic, and in acute inflammation, you get different subsets and different phenotypes. So it would be very nice if this can be in a clinical application, like a blood gas or a glucose treatment. The problem is that's not really possible. It's time consuming, and it takes lots of personnel to get things done. At least that was until 2 years ago, and now we have the device that can actually automatically measure it, and so even the trauma team can do it, which makes things a lot easier and clinically applicable. The good part is it gives you pictures. So this is the picture of depicted patients with their neutrophils after either monotrauma, severe trauma, or very severe trauma. You can see that the configuration of the figure changes as the amount of trauma sustained increases. But it's actually a readout of the system and the entire impact on the patient of the trauma. And here's a short example of of a study we did. I think it's for the very severely injured patients, ISS 30 or higher. That's not really a question whether they or not they will develop organ failure. They are very high risk, but especially the people in the middle, so around ISS of 16, you can see a huge difference in the graphs, how the inflammatory system will react. You can adapt your treatment possibly if you can identify these patients. So if we see these patients and see the inflammatory reaction they have, we try to adapt our treatment strategy based on patient's needs. So either to be able to take the patient back to the OR, we put in 24/7 in-house trauma surgeon. We have dedicated OR facilities, dedicated ICU and capacity. And it can take up to 5 times of short procedures to get the patient back to the OR and get all the procedures done. And the good news is that, well, to get back to Professor Coimbra's remark, this has been calculated with all the same scores, so that might help. But our incidence of ARDS dropped from 30% to 60% over the last 15 years. Our mortality due to organ failure from 25 to 2%, and our mortality due to ARDS went down to 0%. So even with the same scores, I think there is a decline in the incidence and mortality due to organ failure. But it leaves us with a new challenge, and that's that over 50% of these patients will develop an infection. We need to deal with them as concordantly. This is where the neutrophil again kicks in, because we're not over yet. So this is a lot of neutrophils running around eating green bacteria. And you see them all finding the bacteria, eating them, and then making the light go out. So that means that the bacteria are killed. And these neutrophils live for up to 5 days. But if you are after a trauma, so this is neutrophils after severe trauma in a trauma patient, you see they're not moving that much, and the green bacteria are slowly growing. So this is over a period of a couple of days, but the neutrophils are not killing them. So, and even worse, these neutrophils are eaten by the bacteria. So it's the other way around, and in the end, the whole screen will get green. Right? In this case, the neutrophils are like a Trojan horse, taking the bacteria inside and making it possible for the bacteria to cause new infections on more distant sites. We measured that for a couple of days in a row, and what we find out was that the patients who developed infectious complications, these neutrophils demonstrated decreased bacterial killing capacity, and it was the same in every patient. So not only the adaptive immune system is hampered in these severely injured patients, the innate immune system is also hampered for the patients who go on to develop more infectious complications. So I think the risk factors are getting a severe injury and survive it, either being drowned or and getting not the correct timing or an indication of surgical procedures. And especially the last part is, I think, where we would focus on at the moment, because we all know that too much water is not good for you. But we need tools to guide us doing this, the timing and indication of these surgical procedures. I think the inflammatory parameters are a good way to go to guide us in surgical decision making, either for diagnostics but also for therapeutic consequences. Taking it all together, this would be perfect if we can have already some measurements in the field, but at least at the emergency department, making a decision to go to either for more extensive surgery or short surgery, getting perioperative measurements, and finally finding out in the intensive care unit when it's the right time to take the patient back to the OR to do secondary interventions. Thank you for your attention. Giving the word back to Roman.
Thank you very much for this presentation. So we move on to our next speaker, is Professor Balloch from Australia, and he's going to speak about the practical clinical relevance for trauma surgeons. Thank you very much. Professor Balog? So probably in between we can start the discussion. I know Professor Balog. Are there any questions? Probably she just jumped out. Probably the problem of the connections. I just probably start with my first question before we get connected. So, Professor Coimbra, so you told us about this chronic inflammation situation, chronic inflammation syndrome. So, what is a typical symptom of this patient? So, what is the typical period they develop it? Is it the first year or is it the first months? And what are the typical symptoms? They are prone for infection, or how we can recognize these patients?
Yeah, so so the critical illness. Can you hear me?
Yes, we can hear.
Okay, so the critical illness is characterized by a state of persistent inflammation and a state of persistent catabolism. So what you see is a patient that's in this chronic inflammatory state, but is debilitated and worsening over time. There is tremendous muscle wasting, cachexia. The patient is more prone to acquiring infections of all different sorts and different natures because of the state of immunosuppression that accompanies this persistent inflammation. And therefore, they develop chronic organ dysfunction, particularly renal insufficiency, neurocognitive decline, myopathy, and what we call now, putting this all together, particularly in the elderly, frailty. So you look at the patient and you know there is something really wrong with them. And this happens over a very extended period after the initial injury, eventually to 12 to 24 months. And as you measure their outcomes over time, the mortality goes up and the quality of life decreases and the disability that they have goes up. So we have not been able to stop it at some point, this imbalance between pro-inflammatory and anti-inflammatory response. And they go on to develop this chronic state where a pro-inflammatory state and an anti-inflammatory state coexist and affecting the individual from all sides.
Yeah.
Yep.
Yeah, Raul, thank you for a talk about different organ failure scores. And you have shown the huge differences between the scores. And question is, most of these scores are used for scientific studies afterward and to compare patient groups. But what would you recommend on a daily basis at the ICU? I think only very few people calculate during the morning round some organ failure score. They look about parameters. So is it a definition of every day to say this patient goes into organ failure, or do you only address the organs?
So we look at each organ individually, and we use the classic parameters of organ dysfunction. So, for example, pulmonary dysfunction or pulmonary failure for us is PaO2, FiO2 ratios, and the need for mechanical ventilation, PEEP over 10, the usual stuff that we do on every day in the ICU. And I agree with you. These scores, they are important for research because you standardize the nomenclature and we apply to all patients. So if there are differences, you're going to see because you're using only one score. The problem is when you use more than one and you compare them and you see the results that I presented. So for me, SOFA is a very good score. However, we use more SOFA score for sepsis in the ICU, and we use more the Denver score for trauma in the ICU because it seems that it's more realistic and aligned with our resuscitation strategies.
Okay, Professor Popper.
I also have a question, Raoul. About 5 years ago, we were thinking exactly what you described, that it appears that the ratio of post-traumatic ARDS is going down. We were trying to prove it, and it was virtually impossible. It is actually published in your journal. And so we looked throughout the literature, and so my question to you is, do you have any explanation why this trend that we all feel like it is going on, it's not really described?
Well, I don't know, Chris. I think it has been described multiple times. I mean, when we measure our incidence of ARDS, matching patients for injury severity, mechanism of injury, age, BMI, comparing what we saw in the 90s and now what we see after 2010 with more aggressive use of blood, we don't see ARDS anymore when we make rounds. And I'm talking about early ARDS, because remember that some patients will linger in the ICU for a prolonged period of time and will develop late ARDS secondary to significant pneumonia because of immunosuppression. Late ARDS still happens, but early ARDS, post-resuscitation ARDS, we don't see it anymore. It's 1-2%, like Falco described. Very, very little.
Yeah, I completely agree, but somehow nobody talks about it. We know, but I guess we tend to only describe complications and something that doesn't go well. Maybe that's the answer. But thank you.
That's a good idea.
Marco, I have another question. So, are there any typical injury patterns which are associated with multiple organ failure? Is it like thoracic trauma, or always or very often associated with shock? Well, is there a typical pattern that associated with multiple organ failure?
Of course, we know that thoracic trauma has an increased chance to develop organ failure, especially in combination with long bone fractures, I think. But also, those patients are doing rather well these days. So the real question is if it's just one single injury or a specific region that is injured, or whether it's more an injury pattern of multiple injuries adding all together. I think we should look more to the total extent of the injury, the total burden of injury, and not so much specific organs or anatomical regions in relation to the development of organ failure. Although the lungs deserve some kind of special place.
Professor Marti?
Yeah, Falco Impra said in his talk actually that there is no magic bullet, because the whole systems are very complicated at the end. We have several pathophysiological reactions which we cannot really control. And over the decades, we study different ones. We study the humoral factors, the cytokines, endovascular, endocellular vesicles, or cells. And Falco, I have a question to you actually, because you're studying, of course, the neutrophil functions, what you have shown. And in one of your slides, you have shown the first 5 days, the existing neutrophils are working, if there are any. But and then between day 7 and 10, the new generation of neutrophils comes up to help actually, But though we have a window between day 5 and day 7, and is this not the window where most of the polytrauma patients get some infections?
Yeah, that's totally true. So we also did analysis on all the infections in the multi-trauma patients. They have a high peak in day 5 to day 10, which really coincides with the lack of adequate functioning cells. There might be a huge correlation there cannot state that there is a causality, but we have to look into that. But yeah, it's very likely, I think. But and we know that getting a new batch of neutrophils takes about a week. And if you are severely injured, we also know that your bone marrow is quite empty. So in the first day, you will use all of them. They will swim around for about 5 days, and then hopefully after 7 days they get replenished. But that leaves you with 2 days totally undefended. That's the risky period.
Professor Coimbra?
Yeah, so there was a question in the Q&A related to Ingo's question to Fausto that I would like to comment. So in our basic science laboratory in San Diego for almost 30 years, we studied every possible way to decrease this inflammatory response. And every 3 months we said, oh, we got this one is going to be the real one. We try to inhibit TNF and IL-1 and IL-6 and increase IL-10 and change the ratio between IL-10 and TNF. Nothing works. We tried this with hypertonic saline. We tried this with pentoxifylline, phosphodiesterase inhibition, you name it. The one thing that I've been very impressed that we've been working on for the last 10 years is vagal nerve stimulation. Whether you do it electrically in the lab, just shocking the vagal nerve of small animals, or with vagal agonists. And what happens is dramatic, including what is transported through the lymph in exosomes or microvesicles. And so I think that there is a lot of hype about vagal nerve stimulation in the press recently. And I think there is a promise there that maybe we've been all wrong, and what's happening is unrelated to one cell type or two cell types, but it's a disbalance or imbalance between the cholinergic and the adrenergic nervous systems.
I agree that it's probably not just one cell or one humoral factor, or it's the whole system that's gone wild. Yeah, it's you need to find a starting point somewhere, I think, and then work your way up. Agreed.
Oh, Professor
exactly.
Balak, yeah.
It's exactly. It's a global energetic failure. So in any cellular level, just like my computer had a complete Zoom failure, started to reboot itself in the middle of the webinar.
So do you want to start your presentation, sir?
Yeah, I can start now, hopefully. Right. Thank you very much for organizing this, Roman, and the privilege for presenting me here about this exciting topic. I would like to acknowledge lots of mentors and colleagues who either supported or challenged me during the years. So this is where I work now in Australia, but actually this information is being gathered all over the world during the last close to 30 years. And I would like to acknowledge my colleagues who are running the multiple organ failure database prospectively since 2005. And the aims of this lecture to give a 15 minutes, 15 practical points, concepts, things you might not find easily, and it takes me ever to work it out. The first is the emergence of multiple organ failure wasn't described by Hippocrates because it's just a result of our success of care that we are able to keep more severely injured patients alive, and they don't die anymore from single organ failure. And it came together at the time when the intensive care units started to organize. And as Dr. Coimbra mentioned, probably Dr. Bowie published about this first, but Dr. Eisman coined the term of multiple organ failure. And they described it with sepsis and even after trauma when they had catastrophic abdominal sepsis. But later on, Professor Feist and Goris from Germany and Netherlands described that this problem happens in a sterile post-injury scenario without any infection. Most of the things I learned, I got this from these guys, and they infected me about this topic quite a long time ago now. And this is the clinical presentation of this problem. And this patient is relatively easy to diagnose. And one important practical thing, that these patients are edematous. And every time you see edema, that means cellular or organ failure, because the cells just doesn't have the energy to maintain membrane function, which is an elemental aspect of life. So MOF is a rare syndrome. The incidence is about 1.3 to 2 per 100,000 per year, 100,000 per year. It's among the severely injured patients, and the incidence is more or less unchanged because we are better preventing it, but more patients survive to get to this situation. But the mortality is decreased significantly, but still around 20% these days. So the relationship with traumatic shock, the important aspect that we define this problem not based on the shock-related organ dysfunction, but after the shock resuscitated around 48 hours. So the early organ failure means that which is prevents practically straight after shock around 3 days, and the late presents after a tranquil period, after a normal function, which anywhere after 3 days. So we discussed in detail these risk factors, but among the typical patient is the obese elderly male in traumatic shock. And from the comorbidities, really the liver and the kidney failure what counts. And the key thing is the patient who is not able to clear their metabolic acidosis. And we used to say this is 24 hours, but actually today we would say that much, much earlier. If patients clear it 6-12 hours, they are out of this problem. And again, the other success is that today the risk factors are injury severity and shock parameters are not as strong as used to be because we are uniformly resuscitating sick patients much better. So the prevention is the rapid hemorrhage control, the judicious resuscitation, and basically limit the suffering from immobilization and unfixed injuries. And the proactive management of single organ dysfunction, because if we prevent one organ to fail and lead to the second, obviously we prevent multiple organ failure. The next one is the myth around second hits. It's genetically unproven that you cannot hit someone twice and have worse inflammatory response. But the very important thing that you can make them sick if the homeostasis is not maintained. So we don't make these patients sick with surgery. We could make them sick if they not maintained homeostasis. And our latest data shows that it doesn't matter when you operate as long as the patient's homeostasis is maintained. And we have to balance always the risk of surgery versus the risk from immobilization and protracted care. Number 8 is the timing for interventions. 70% of the MOF patients have surgery before MOF. And this is not the life-saving surgery. This is the plannable surgery. And if you have no physical derangement during surgery, there is no increased mortality. There can be about a 15% margin of increased ICU length of stay with wrong timing of surgery, but they not necessarily died. These patients don't die anymore. And we have very simple, straightforward parameters. which probably with artificial intelligence, we can bundle better. And all those parameters that we measure already with specific patterns, we can recognize and predict who is going to get sick from surgery. And you don't need magic parameters for this. So in terms of multiple organ failure scores, my take-home message is that SOFA is sensitive and less specific. Denver is less sensitive but very specific. So if you want to have lots of MOF, use SOFA. If you want to have the ones which you really need to treat, use Denver. And absolutely no consensus, neither population or scores or cutoffs. No specific treatment, but the evidence-based support of individual organs does work. And so you need to support organs before they fail. And probably the future lies somewhere the global mitochondrial function reprogramming. The pattern of failing organs also changed. Historically was lung failure, the leader, but today the most frequent organ failing is the cardiac system. But the most lethal single organ failure contributing to multiple organ failure is liver and kidney. So any of those who are relatively rare but have liver or kidney failure, they're more likely to die than the others. In terms of outcomes, this is the ultimate complication in politrauma what we need to avoid. And it has still about 20% mortality. But if you compare to those patients on the ICU with same injury severity without MOF, their mortality is only about 3%. So this is a huge problem, and they stay 2 weeks on the ICU compared to 3-4 days to the other severely injured without MOF. And the important thing that this leads to a chronic disease status by any definition, and all these patients has a decreased life expectancy, even they survived MOF successfully. So in the future, we need to focus on those factors which are modifiable. And these are already proven: the traumatic shock management, minimizing further tissue injury, minimizing immobilization, and preventing or rapidly eliminating infections, and the preemptive support of organs do work. I would like to highlight that the immobilization is very important. In a laboratory animal, you can generate multiple organ failure and hyperinflammation just by immobilizing the animal for a few minutes every day. And that's what we are doing on ICU on patients for days unless we fix them early. So consensus, we need to standardize the population, the denominator, what we investigate, and we need to standardize the definition, the score, and the cutoff. Otherwise, we can't speak the common language. We can't monitor long-term the epidemiology and the outcomes, and we cannot use this basis for a platform for interventional studies. In the future, number 15, multiple organ failure continues to change its look and how is it present. We have seen many different ways that this syndrome looks like, and it didn't look like in the last 5 years. It was very different before. And it's going to be more challenging when we're managing elderly comorbid population. We need to have an idea how to restore the cellular energetics, which is the global problem behind it. And if we identify better the at-risk geno and haplotypes, we probably can develop a powerful vaccination against this problem. So in summary, it's a rare, ever-changing lethal syndrome. If the sensible, proven approaches for preventions do work, and we achieved a lot on this, but fundamentally new approaches are also needed to develop consensus about the common language and restoration of the cellular energetics in the global function to improve outcomes. Thank you very much.
Thank you very much. We have 5 minutes for a discussion. Are there any questions? So, Professor Balog, I have a short question. So what is the role of anesthesia, anesthesiology, operations, and so on? So it's not always a tissue damage due to surgery. What is your opinion on it? So does it play a role? Anesthesia?
Well, that's what we looking at this time, because we couldn't find anything in terms of surgical interventions which would make these people sick or sicker. But something must be related to the time when they go to the operating room. And if you consider that how many medication have major effect on cellular energetics and mitochondrial function, just looking at isoflurane, propofol, and most of the antibiotics. This is something which we are trying to explore, that we've been used to blame that surgeons make the patient sick, but you can make patients very sick just with medication. And immunological functions, for example, opioids, bottom down immunological function, natural killer function, and the rest of the acute protective inflammatory function. So it's a very relevant area to explore, I believe.
Professor Marty?
Yeah, actually, what we have heard now is that we have a general cellular dysfunction. And the question is for the timing of surgery. So you say immobilization is a great factor which influences outcome. On the other hand, we have to operate them not as emergency, but within the first days or weeks to get them mobilized. Yeah. So what is the real time point now to do, for example, completeness of extremity surgery, spine surgery, pelvic surgery? How should we judge the restoration of the hemostasis or the cellular functions?
Well, this is a great question, Ingo. I think you're probably confused on much higher level than me on this, but if you ask me, the issue with as long as your patient during surgery not getting worse, and we showed basically on 400 high-risk patients that the preoperative and postoperative laboratory, respiratory, and all the values are exactly the same. So nothing changes. So basically, with modern anesthesia and trauma specialist anesthesiologists able to pull this phase through. And I believe that the major axial skeletons, such as spine, pelvis, and long bones, is probably worthwhile to fix. And we have a data set which we're just evaluating that in patients who we operated in multiple organ failure, in the middle of it. And actually, that didn't increase the mortality compared to the ones we didn't operate. So that's something which we really need to consider, that how important is that you can sit somebody up, decrease the pain medication, get off the ventilator, and that's something is a huge benefit.
Professor Coimbra?
You're mute.
Sorry. I'm just going to throw more wood in the fire here because, and it'll be provocative and controversial. You know, this idea, this two-hit theory to me is bogus. We already proved that two-hit theory doesn't exist. What exists is bad resuscitation that primes the immune system to respond differently if you have a second aggression. So it's all about what you do first It's not about what happens second. And furthermore, we have shown with adequate resuscitation now with more blood and ratios and all that, that if the patient doesn't go down the drain in the first 3 days, it's not a second operation that's put the patient over the edge, unless there is infection associated with the second procedure. So when you introduce bacteria in a situation that so far has been sterile, then the cycle of multi-organ failure may start again. But I don't think that the second insult does anything if your initial resuscitation was able to maintain and restore physiology very quickly. I think this is old dogma that should go away.
So last question, Professor Pap, or last two questions, Professor Pap and Professor Marzi.
It's not a question, it's more like a comment. I have the feeling that 15 years ago, those patients that developed multi-organ failure were the ones that had a prolonged problem to seal their vascular leaks. And so they were on a positive IO ratio for a prolonged period of time. Coagulation didn't normalize until maybe a week after the injury. And those were the ones that kind of dwindled off slowly and without us being able to do anything. And now I think that we see it much less frequently. But what we see instead is patients, if they do have a secondary deterioration, it is triggered by infection, and it's most of the time it's a pulmonary infection, and then all of a sudden sepsis develops, and it's like a true sepsis. That's my feeling. I just wanted to say that.
So if there are no questions, I would like to close the session. I think the time is over. I would like to thank all speakers for this excellent presentation and a very good discussion. And I hope we see each other next time with our webinars. So thank you very much and see you next time.